Hi, I'm Dr. Scott Lederhouse. We will be discussing at this time issues regarding cervical spine surgery. We'll go through consenting issues, we'll show scans and give you more information on exactly what it is that we do, show you the models so that you understand as best anyone can what it is that we're discussing. This video is not intended to replace the consent or discussion that you may have with your surgeon, so please just consider this as supplemental information, and any further questions that you may have, certainly direct them towards your treating doctor. So this is a model of the cervical spine. This is the front portion of the cervical spine. It's also called anterior. This is the back portion of the cervical spine called the posterior aspect of the spine. The numbering system for the cervical spine is cervical, or C1, 2, 3, 4, 5, 6, 7. The next one is designated first thoracic, or T1. We can see that there's the disc spaces and disc material between each cervical vertebra. In addition, we see the nerve roots which come out at each level and go into the arm, and each nerve root goes to a specific muscle, and it may supply a specific reflex, and it may also supply specific areas of sensation of the skin in the arm or hand. As well, we can see this red thing here, which is called the vertebral artery, and it courses between what's called the transverse process and what's called the foramen transversarium from the lower cervical spine up into supplying the brain. This is the model of the cervical spine visualized from the front or anterior aspect of the spine, and turning it on the side, then we see on the posterior aspect of the spine. The MRI scans on the what are called sagittal views are taken with sequential cuts going from one side to the other, looking at it from the side, such as this. There are other views on the MRI scan that are called axial views, which are views that are taken in this manner here, where we have the vertebral body or disc in front, the spinal cord in this position, and then the holes where the nerves exit and go in towards the arms through their holes, which are called the foramen. So these are the images that we'll see on the MRI scans. This is a cross-sectional view of the spine demonstrating a herniated disc on the right side of the picture. We see the spinal cord in the center with the exiting nerve roots. This is a typical picture of a herniated disc. This is a diagram of the sensory areas involving the skin with each corresponding nerve root distribution. Therefore, we can get an idea which nerve may be. On the examination, we get an idea which nerve may be involved by the weakness pattern or the reflex changes or the areas of skin that may be numb or tingly, as in these diagrams. This is a side view image of a normal MRI scan of the cervical spine. The numbering system for the cervical spine is C2, 3, 4, 5, 6, 7. Then the upper thoracic spine is below that, starting with T1 down at the bottom. This is the front part of the spine, or the anterior aspect of the spine, and this is the posterior part of the soft tissue of the neck, or the back of the neck. This gray thing coming down is the spinal cord, and then the white that's on either side of the spinal cord is spinal fluid, which looks just like water and bathes itself around the spinal cord. We can see the discs at each level, and they're designated the level of the disc depending on which bone level they're at. So this is the C2 and this is the C3. So this is the C2-3 disc. This is between 3 and 4. This is a C3-4 disc, C4-5, C5-6, C6-7, etc. This is a normal axial view of the cervical spine, and this is designated between the C4-5 level, as the marking indicates here, and this is a view with the bone or vertebral body or disc in front. So this is the anterior vertebral body, posterior back part of the spine. This gray thing in here is the spinal cord, and then again the white around it is spinal fluid that surrounds the spinal cord. What we see here is the hole where the nerve exits, which is called the foramen, and the foramen is normal on both sides of this image. This is another normal, what's called axial view of the cervical spine, designated between the 5 and the 6 level. Again, the image quality here is quite good. This is the bone in front, spinal cord, spinal fluid, and then the holes where the nerves exit on both sides. The image quality obviously can vary from patient to patient, the patient's body size, the machine that's used, and generally closed units, which are a more claustrophobic MRI scan, generally give better pictures than open MRI scans. This is another axial image, again at the C4-5 level, and in this case we see a normal hole where the nerve exits here, and on the other side the hole is somewhat narrowed. In this particular case, the nerve could be compressed as it exits through that hole on the picture's left side, which is actually the patient's right side of the body. This is an axial picture at the C5-6 level, demonstrating a normal hole where the nerve exits on this side, and over here there's a grayish material that's filling the canal where the nerve passes. This would compress the exiting nerve root and give radiating pain down the arm in the distribution of that nerve root. This is a side view or sagittal image of the cervical spine, and in this case we can see that not all the discs are perfectly normal in size. We see narrowing of disc spaces at multiple levels. The disc space is thinned at multiple levels. We have a little bit of bone spurs that we can see going back towards the spinal cord, but it appears that the spinal cord gets through without any compression effect. These changes in the vertebral bodies themselves are what we would call diffuse degenerative changes, also some arthritic changes. The terms are sometimes used interchangeably. When we perform a cervical spine operation, we make an incision in the center part of the neck and generally off towards the right. So most common would be down in this location. So we'd make our incision from the center to the right and making our incision over the area of where the disc herniation or bone spur or problem exists. After putting a retractor in, we're looking at a small area that may only encompass this large of an area with the retractor in place. Then under the operating microscope we can remove the disc material, and then we have a little device or a little instrument that will actually open the disc space up slightly so that we can see the nerve roots after we remove the disc material. Once we've removed the disc material and opened up the holes on both sides, and in some cases taken pressure off the spinal cord, then we take a piece of bone graft that goes in the disc space that measures usually about the same height of the disc space, and that bone is what we get from the bone bank, but we also do a little bit of drilling of your own bone, and so we have some of your own bone dust, and that bone dust goes into the piece of bone that is then put in between the disc space. This is a model of a typical plate that we would use. There are several plates and they all have the same function and serve the same purpose. This happens to be a two-level plate, and this plate model here has one screw here and one screw down here, but at each level we would put two screws into the bone, and this would be where the bone graft sits underneath this level here. And the screws generally have a lock-in mechanism to keep the screws locked in position so that they don't pull out. And as you could imagine, then when the plate is in position, the motion above and below the plate continues. However, right at the level of the plate there's no motion. But this plate is it's a thin plate. It contours to the shape of the neck, and this plate doesn't interfere with swallowing, etc., and generally we'll leave this plate in after the operation is done. However, if there was a disc problem, say at this level or above, then this plate would be removed, providing that everything had healed properly, and then a similar operation be done at a lower level, putting perhaps a smaller plate at one level as well. This is a side view image of an MRI scan demonstrating a large herniated disc between the C4-5 level, which demonstrates significant spinal cord compression. This patient obviously needs an operation. This is an intraoperative photograph demonstrating the bone graft which has been placed where the disc had been removed, and demonstrating the space where the bone graft sits. This is the same patient after the operation has been completed, with the bone graft in position and the plate on at the C4-5 level, and these are what the images look like after the operation has been completed. This is another MRI scan demonstrating degenerative changes and disc herniation at the C4-5 and C5-6 level with significant spinal cord compression, and as well this patient needs an operation. This is the same patient after placing a longer bone strut with a plate spanning the area from C4 to C6 with the spinal cord decompression. This is a post-op MRI scan demonstrating the same patient after the spinal cord has been decompressed, noting the now room for the spinal cord to pass at the levels that were operated on. Well, now we'll be talking about consent for the cervical spine operation. And in your particular case, the consent or the procedure may be due to bone spurs compressing the nerve roots and or spinal cord, or possibly a herniated disc that's pressing the nerve roots or spinal cord. And you may be provided a consent form that would look something like this, and at this time we'll go over this particular form. At least at the top of this form, and the consenting process may be different depending on whether this form is available or not. However, the wording or information that I'm providing will be valuable. Anyhow, this form says surgical risk, potential complications, and indications for cervical discectomy with fusion and plating. Now the fusion is putting a piece of bone in between the disc space, and of course the plating is an application of the titanium plate and screws across the disc space. First portion says skin, potential risk of infection, poor wound healing, scar formation, and skin contracture, and that basically just depends mostly on how the wound heals. Infection rate is very low. We give antibiotics at the time of surgery, and I can't recall the last time we had a cervical infection. Numbness above and below the incision occasionally is noticed more by men than women, and if it occurs, it generally disappears after a couple of months. Next portion on the consent is soft tissue. It says injury to the trachea, which is the windpipe, esophagus is the food pipe, jugular vein and carotid artery with excessive bleeding. All of those structures we haven't had an injury to. We're using blunt dissection, generally with our fingertip, and as a result we haven't had injury to those structures. These are potential risks that could occur. Stroke from carotid artery injury, also we haven't seen, but we're working right up near the carotid artery when we do this operation. Recurrent laryngeal nerve injury with a hoarse voice is a rare complication. We've seen a few of those patients, and what that refers to is a stretching of the nerve in the soft tissue of the neck called a recurrent laryngeal nerve. Now we never see this nerve at the time of surgery, and its courses in the soft tissue of the neck, and the place where it's most commonly stretched is at the lowest cervical vertebra, what we call the C7T1 level. Occasionally you'll also see it at the level above that at what we call the C6-7 level. But in either case, if the nerve gets stretched, it makes one sound as though they have a laryngitis for a period of time, and in most patients that will clear within a month or two, and we haven't seen anybody with a permanent recurrent laryngeal nerve injury. Swelling of the soft tissue of the neck with respiratory difficulty, again we haven't seen that, but if you could imagine after completing the operation before closure, if there was bleeding that we didn't see and the wound was then closed, it could put pressure on the windpipe. Again, we haven't seen that, and at the end of the operation before we close, we search meticulously with the microscope to make sure there's not any bleeding points. So we haven't seen that as a complication either. Last one is injury to the vertebral artery with possible stroke, paralysis, death, vegetative state. And the vertebral artery is an artery that courses in the bone just immediately lateral to the vertebral body. And again, we haven't seen an injury to this vessel either. So this is a potential risk, but we haven't seen this occur. Next section is bone, says infection with osteomyelitis. So a bone infection is osteomyelitis, and again, that would be a very rare event. Nonfusion with pseudoarthrosis and chronic neck pain, so that would imply that the bone plug that we put in does not properly fuse. Eventually the plate and screws would break and fall apart, and again, we haven't seen that occur. We have not, at least to this point, seen a patient who hasn't gone on to fuse with using the technique that we're describing here. Collapse of the bone graft or dislodgement of the bone graft or resorption of the bone graft. Similarly, with the use of the plate and the bone graft that we use, we haven't seen any movement to the bone graft or collapse of the bone graft. Additional wear and tear of the bone above and below the site of fusion. So that means that if we fuse one of the levels and put the plate across, the level just above that, or the disc space just above that, and the disc space just below that will incur a little bit more wear and tear change, and that could potentially increase the chance of developing bone spur formation over time in the neck that could lead to a problem with the pinched nerve in the future, or potentially even a herniated disc. Now these are small risks, but they're not 0% chance either. Postoperative interscapular pain, and that's pain between the shoulder blades, and that's a referred pain from putting the bone plug in and the plate on, and in patients that have that, it usually goes away within a month or so. Next portion is titanium plating. It says infection, loosening of the screws and plate, dislodgement of the plate and screws, and fracture of the plate and or screws. So we haven't seen a plate-related failure to this point, such as the plate breaking or the screws breaking, but on a rare event in someone who's severely osteoporotic, where the bone is very soft, we have seen a couple of the screws come out. So that's a rare event, and again is more so in patients that have abnormal bone to begin with. And then it says removal of the plate and screws. So if everything is healing properly, we don't do another operation to go back in and remove the plate and screws. However, if there was an operation done at the level above or below where the previous fusion had been performed, then we would remove that old plate and then more than likely put a new plate on. Next portion says spinal cord and nerve roots. Injury in part or the complete of nerve root function at the site of surgery. Injury to the spinal cord with possible complete quadriplegia, with loss of bowel and bladder and sexual function, or incomplete spinal cord injury. So these are all potential risks and complications again, and as I mentioned, we're using the operating microscope. Everything is real large, well lit, and so we can see what we're doing, and as a consequence we haven't had any inadvertent nerve root or spinal cord injuries on the cases that we've done. Next section, or next paragraph there says residual piece of disc with ongoing nerve root pressure possibly requiring redo surgery. That would imply someone who has a large herniated disc with multiple fragments of disc that are along the course of the nerve root. And if every last bit of disc can't be seen or removed, then the patient may wake up and still have ongoing arm pain. In that case, then we would redo an operation, generally while the patient is even still in the hospital. And we have on a couple of occasions found a couple of pieces of disc that we for some reason couldn't see on the first go around. But again, that's a very rare event. General risk, no improvement or worsening of condition, and that's why it's important to be specific on where your nerve root problem is. Obviously, someone who may have a pinched nerve in the hand, such as a carpal tunnel syndrome, who ends up getting a neck operation, well, that's not going to cure the symptoms into the hand. Similarly, if someone has a pinched nerve at one level and we're operating at another level, then the symptoms would not improve under that situation either. So we try to be as specific as one can possibly be on which nerve root may be causing the problem. And in that potential situation, then the patients do well once we're very specific on where the cause of the problem is. Next section is general risk, says no improvement or worsening of condition. Death due to the anesthetic or surgery, either direct or indirect cause. We haven't lost anybody doing this operation. Scar tissue formation, allergic reactions to medications, risk of AIDS and hepatitis from a blood transfusion, and the amount of blood that we ordinarily lose is very minimal, and we've never had to give a transfusion for this sort of surgery. So the likelihood of needing a transfusion would be essentially zero or close to zero. Prolonged hospitalization for some complications with possible long rehabilitation, and that generally would speak of perhaps an elderly person or perhaps someone that has severe spinal cord compression symptoms that just needs a little extra help and physical therapy and rehab prior to going home. Stiffness of the neck, especially if more than one level is fused. Now, generally speaking, patients that have a one-level fusion don't complain of any particular stiffness of the neck in rotation, flexion, or extension. However, certainly if there is more than one level, and particularly if there are, say, 3 or unlikely 4 levels being fused, then that patient would notice more progressive stiffness of the neck. But a one-level surgery, generally there's no noticeable stiffness of the neck. The above risk and potential complications are not meant to be a complete list of all potential complications or risk, and therefore may not be limited to what has been listed in this outline, such as someone who comes in and has an unrecognized heart problem with a heart attack, or a lung situation with a pneumonia, or some other unrelated event to the actual cervical spine itself. Work restrictions. It says soft cervical collar is worn for approximately 30 days. And I do things a little differently than Dr. Disney or Dr. Rodriguez. Dr. Disney may have you wear your soft cervical collar for the entire 30 days, day and night. Dr. Rodriguez may have you wear it most of the time. And I usually tell patients to wear it only while they're riding in the car for the first month. But if you're otherwise lounging around at home or walking around your neighborhood or sleeping, you don't need to wear that. And then the next part says no driving for approximately 30 days. And that's all a relative issue as well, and there's nothing written in stone about that. However, the patients who do resume driving need to be off any prescription pain medications or muscle relaxers, as they can make you sleepy, and it's illegal to be driving under the influence of those drugs. And as well, if someone were in an accident on day 31 after the operation compared to someone in, say, day 3 or 4 after the operation, there's not going to be enough bone ingrowth to protect someone if there is involvement in a car accident with potential neck injury. So the 30-day is somewhat of a relative period. Again, I usually tell patients if they're off prescription pain medicines and prescription muscle relaxers and they're feeling comfortable, then they can drive initially, starting with short distances. Again, so this is a relative issue. It says no house or yard work for 1 to 3 months, and initially starting just fixing your own meals, not doing any strenuous activity, not doing any yard work or housework, and giving things a chance to settle down before you resume more normal activity. Generally speaking, by the time 3 months approach, you should be able to do unrestricted activity with respect to yard work, housework, and your employment. However, you may want to avoid such activities as water skiing or skiing for perhaps anywhere from 6 months to a year, just to ensure that there's proper healing and bone growth before resuming an activity such as that. Then it says, depending on job requirements, disability may range from as little as 1 week postoperatively to 3 months or more. Again, someone who does desk work can resume work whenever they feel comfortable to do that, and someone who does heavy work such as construction may need the full 3 months rehabilitation before returning to that line of work. And it says certain risks must be considered with any surgery. Although every precaution be taken to avoid complications, absolute guarantees cannot be made. Clinical experience and judgment indicate that in general surgical risks are limited. However, surgery remains a human effort. Unforeseen circumstances can complicate any surgical procedure and lead to serious or even life-threatening situations. Although such complications are infrequent, you and your family should feel free to discuss the question of risk with the physicians. For any uncertainties patients may have, we encourage second opinions from other qualified neurosurgeons. I've discussed the above pertaining to cervical spine surgery with my physician. He has explained the procedure and nature of the operation, the risk and complications to be in non-medical terms so that I understand them. I have discussed alternatives to surgery with my physician. I've been provided a copy of this form for my later review. And then it'll say my diagnosis is, and it'll be a specific nerve root or spinal cord compression, whatever the diagnosis may be. And I give my consent for the doctor to perform the following operation, and it'll be a specific operation. It might be C5-6 discectomy with plating and fusion, or C6-7, or a combination of those procedures. So that'll be up to your treating doctor and yourself what the actual specific name of the operation would be. And then we ask you to sign this, and if you come with a family member or friend, to have that person witness the consent form as well. So I hope this has been an informative process for you, and you've learned what it is that we do and why. And if you have further questions regarding this, please feel free to ask us, as this is not intended to be the full consent or information that you would receive, and certainly we would go over your scans with you and explain exactly what it is that you have and what our treatment plan would be. Thank you. For the admission to the hospital, we will generally have patients come in about 2 hours prior to the designated time for the surgery. And we would have to be what's called NPO, which means nothing by mouth, for about 8 hours prior to the surgery. If you take regular medications for blood pressure, etc., then you can take those with a sip of water when you would ordinarily take them. However, if you're diabetic, then you would need to speak with us about how to manage your medications. If someone is on oral diabetes medication, then we'll usually not give the morning dose of that medication and then resume those medications once you've begun to eat again. And as well, if you're on insulin, then we would have to speak to you specifically about that. And we usually will request patients stop taking products such as aspirin for about a week prior to surgery. And if there was an issue of someone being on a blood thinner such as Coumadin or Plavix, then again you would need to speak with us specifically about termination of those medications and when we would be able to operate in that situation. As far as the admission to the hospital, patients will come in and usually a day or two prior to the surgery will ordinarily have a chest x-ray, often have an electrocardiogram, get a couple of blood tests done, and then you'll be set to be admitted on the morning of surgery. The girls who do our scheduling will provide you with lab slips and information on where to go at what time and what time your operation will be. So there's nothing you need to remember at this point. And that'll either be mailed to you or given to you at some point in time prior to the operation. As far as any blood transfusions, we haven't had to give a single blood transfusion for doing an otherwise ordinary cervical discectomy. Exceptions to that rule would be if somebody had a tumor or something along that line in the spine, which we would know ahead of time, and that can sometimes result in needing a blood transfusion. But for the ordinary disc herniation or bone spur removal, we haven't had to give a blood transfusion as we lose very little blood. As far as medications afterwards, you'll usually go home with a pain medication. Ordinarily it would be Vicodin and a muscle relaxer, which might be Soma or Flexer or whatever muscle relaxer you might have been using. And there'll be directions on the usage of those medications. We encourage you to take them if you need them. However, if your pain is subsiding, you don't need to take those medications, and you can wean yourself down to either, say, plain Tylenol or even Tylenol combining that with some Advil. And Advil doses would be on the order of maybe 3 Advil 3 times a day if you're weaning yourself off of the prescription pain medication. If you need refills, call your pharmacy, and then they would send us a note we would sign and then send back. And if you do see that you'll need medications, it's best to call us usually in the middle of the week and try to avoid weekends, because the person on call may be swamped and not able to call back and do medication refills on a weekend. So try to make plans to get your refills done prior to the weekend coming around. Now, when we close the wounds, we generally close in what's called a subcuticular manner, which means it's dissolvable suture on the inside of the skin, and there's no observable suture to remove. The suture itself will dissolve, and we'll oftentimes put a substance over the wound called Dermabond, which is a liquid that is somewhat of a cement type product, somewhat like PVC cement, but it helps seal the wound and makes essentially a watertight wound closure. When we apply that Dermabond, then it's essentially waterproof, and you can be showering, etc., but not submersing in underwater until we inspect the wound and make sure it's properly healing. We'll usually have patients come back about 2 weeks after the operation, primarily to inspect the wound and see how you're doing and answer any additional questions. And we may see you on periodic visits over the next couple of months. As far as your return to work date, that would be worked out between you and your physician as far as what type of work you do and when you can return to work, and as well discussions regarding driving and resuming normal activity around the home, etc. The hospital stay for this sort of procedure is often done as an outpatient, and if you're able to at least swallow well and not requiring shots for pain, then you can go home. And again, ordinarily we'll do this as an outpatient procedure. If for some reason it's a more than one level procedure or under certain circumstances, then the patient may need to be admitted overnight and discharged generally by the following morning. It's not a particularly painful operation, and there may be some restrictions on swallowing initially in that you feel as though there's a little bit of trouble getting liquids down. But as far as taking pills, if you break the pills up into a powder using a couple of spoons together and then put that into some applesauce or something that's easy to get down, then that makes it easier than swallowing a whole pill. So that can be done as well. As far as follow-up and x-rays, there's no particular hard, fast rule if we get x-rays or how often or when. If we're concerned about something or want to ensure healing, then we'll sometimes get x-rays. But again, it takes usually about a year for the bone to completely incorporate and show a solid fusion on an x-ray. So initial x-rays aren't really going to be of much benefit unless somebody, for example, has been in a car accident. We just want to make sure that the screws and plate and everything are still intact. Then we will obtain an x-ray. So we may or may not obtain any x-rays, and if you're doing well, then we'll discuss your activity, etc. So we hope that you've found this information useful, and again, this is not intended to take the place of the consenting procedure or additional information provided by any one of us, only intended to give you additional information and pictures so that it becomes more clear what it is that we're trying to treat and what we're trying to do. Anyhow, I hope that all goes well for you and you have a quick recovery, and we hope to see you soon. Thank you.